Good morning, everyone. Welcome to the Aurora Health Alliance Access to Specialty Care Interest Group meeting. I hope everyone's summer is off to a good start. Thank you so much to Dentaquest for sponsoring the Access to Specialty Care Interest Group. Sarani has a few minutes on the agenda to provide a sponsor spotlight. So Sarani, take it away.
Great, thank you so much, Ashley. And buckle yourselves in. This is going to be a dental palooza here for the next about 10 minutes. And I appreciate your attention. We are really pleased to be able to cooperate and collaborate with the Aurora Health Alliance and specifically this interest group, because there is such a strong connection between the whole body and also your oral health. So I'm going to talk a little bit this morning about who Dentaquest is and what our role is and how you might be able to also support oral health in regardless of whatever specialty practice that you're in. So I'm going to go ahead and share my screen. My name is Sarani Young. I'm one of 2 member outreach coordinators in the state of Colorado with Dentaquest, and we oversee the dental benefit administration for Health First Colorado and the Child Health Plan Plus. So today's discussion will be very quick. I will save time at the end for questions, but I'll also put my contact information in the chat if you have any follow-up questions around the dental benefit or just Medicaid dental benefits in general. So today we'll talk about Dentaquest's role in Colorado, a little bit about the importance of healthcare with the understanding that I know I'm probably preaching to the choir with all of the professionals who are on the call today. Talk about the physical and oral health connection and why it's so important for us to be all working together to focus on the whole health of the members that we work with. I'll go very quickly over what are some of the dental benefits for Health First Colorado and the Child Health Plan Plus. And then finally, a little bit more about what I do, how members can receive education, the types of tools that are available to them, and the supports as well. So first and foremost, who is Dentaquest? So we contract with healthcare policy and financing, and we administer the dental benefits, as I mentioned before. We do not set what that policy, what those benefits are. That is all set by the department and also by the legislature. And we are a statewide organization, so we manage the entire provider network, all oral health providers across the state. So we have 2 major focuses here in Colorado. We have a tremendous team, all of our network managers who conduct the provider support. And so they really are the central point of contact for all oral health providers and staff. If any providers have questions, we have the staff members for them to be able to go to talk to. They handle all of the billings and claims questions. So the network managers are the ones who are going to be out there putting out the fires if there are any questions about the billing. And they're also responsible for recruiting the providers to make sure that we have that adequate network across the state. So you can see here, I have 4 colleagues in our provider engagement department, and they cover the entire state. Their contact information is here, but if you have any questions, certainly reach out to me and I can be the conduit to put you in touch with any of our network managers. On the member support side, and that's myself and my colleague, Sabrina Crawford, first and foremost, our task is to build Health First Colorado and THP Plus plan awareness. I do this all day long for a living, but it's always surprising to me to see how many members actually don't even realize that they automatically get dental benefits as part of their eligibility and enrollment with Health First Colorado or CHP Plus. So we want to build that plan awareness. A lot of what I do is helping find a provider for people if they're at a loss as to how to be able to connect with a participating provider. It's part of my soapbox. I really strongly promote that oral health and oral systemic connection. So that's part of our participation today in engaging members wherever they are, whether it's through health fairs, community events, presentations like these. That's part of my job, is to be present in the community to make sure that people know about their dental benefits and how to access them. And then also a lot of what I do is helping individual members navigate the grievance and appeals process if it comes down to that. So here's a map just quickly to show my assigned territory is the eastern side of the state and the Denver metro area. And then my colleague, Sabrina Crawford, handles the western slope. I'll go over this quickly because as I know you're probably quite aware of that oral systemic connection, but I was surprised to see that 93% of individuals living in poverty have unmet dental needs. And surprisingly, there's only a 38% access utilization for Colorado Medicaid members for their dental benefits. So we have a good uphill task ahead of us at Dentaquest to be able just to let people know that they have dental benefits and encourage them to be able to access those dental benefits, especially in the rural and frontier counties. Those in poverty spend 10 times more as a proportion of their annual family income on dental services compared to high income families. So another part of our charge is really helping people get into those preventative services so that it doesn't get to a more intensive intervention. Just these I thought were some interesting statistics that came out of Colorado, which is 1 in 4 people avoid smiling due to their condition of their mouth and teeth. And part of what I do when I'm educating people is to help them understand that really taking care of their teeth is part of not only their whole body health, but if you're going for a job interview, your self-confidence. Children who are in school, if they're experiencing pain, they're not going to be able to focus if their mouth is hurting. So we really want to be able to help people access those benefits, as I said, and make sure that they're staying healthy. So you can see here that gum disease is really an integral part of all of these different types of chronic conditions, not only Alzheimer's, arthritis, cancer. There's a huge connection between uncontrolled gum disease and if you have uncontrolled gum diseases and uncontrolled diabetes, there's a huge corollary between that. Heart disease, all of these other things, kidney, lung, stroke, these are the kinds of things that the mouth is really a window to the rest of your body. And oftentimes an oral health provider will see some of these chronic conditions manifest in the mouth before even a physical doctor will. So that's why it's so critical for oral health providers and physical health providers to be in contact with each other and to be able to have that cross-pollination to be able to help the patients that they're working with. One of the initiatives that we have that we call Take Two to Make Two is really to be able to encourage both dental and medical providers to encourage their members when they're taking the time to make an appointment to go ahead and take that extra couple of minutes to be able to make an appointment with either a medical or a dental provider. One should be visiting their dental provider every 6 months and their primary care provider at least once a year. And that's the messaging that we're getting out to our members and hopefully to both medical and dental practices so that members are seeing both their care providers throughout the year. I'll do a really quick rundown because I know we are short of time, but if you have any interest in finding more details about this, please feel free to reach out to me. Under Medicaid, some of the dental benefits include exams, x-rays, cleanings, fillings, all of these types of interventions. It's also important to note, you'll see the asterisk next to dentures and partials and dental emergencies. This comes out of a separate pot of money. So adult members have a $1,500 benefit each year for their dental. And those dentures and partials are not, if you need to access those benefits, that doesn't dip into that $1,500 benefit. Kids 20 and under actually have the EPSDT, the early periodic screening, diagnosis, and testing benefits come in as a wraparound for children. There's no annual maximums, no deductibles or copays, and there are no copays for adults either. Covers a wide range of preventative and restorative care and emergency services. For children, orthodontics braces are covered if they're deemed medically necessary. So that is a covered benefit under Medicaid. As I mentioned, there's a $1,500 dental benefit. I did leave this on here. There was a planned reduction down to $1,000, but the good news is, and I'm happy to report that that actually will not be coming into play. So happily, the $1,500 benefit is going to stay the same for adults even after the public health emergency ends. There is an expanded benefit for those who are on the DD waivers. They get some additional funding up to $10,000 in major dental benefits over a 5-year span. So it's a little bit of an expanded benefit for that particular waiver program. Under the Child Health Plan Plus, similarly, there are a wide variety of different diagnostic services that are covered, annual exams and x-rays, basic restorative. Braces, orthodontics are covered when medically necessary under the CHP Plus program as well. For CHP Plus, we covered children up to age 18, and then starting in 2019, that coverage also expanded to include pregnant women. And there's a $1,000 benefit maximum for the CHP Plus. The copays there's a small copay associated with CHP Plus, but that's also based on income. There's on a sliding scale fee. We have a very robust Find a Dentist feature on our website. There's also the opportunity for members to register and sign up for our portal, where they can access that 24 hours a day. You can see there, the website is there if you're so inclined, if you wanted to explore or direct one of your patients to be able to get there. There they can find providers. We have our member access to the member handbook, a lot of different information. They can track their benefits throughout the year. And that is available to both CHP Plus and Health First Colorado Medicaid. Our Member Support Service Center is open 8 a.m. to 5 p.m. Mountain Standard Time. They can help them to be able to find a provider. They can help them navigate the appeals process. Also, they can actually help them make an appointment if they would like to be able to call through our member services. As I mentioned before, they can help them with appointments. They can help them find a provider. They can help them get in for an emergency dental. These are all the different various things that they can access when they contact our support center. So for making an appointment, they can both call our member services, or they can also go online to be able to find the dentist tool. It's important to remember that the dental office should check for eligibility when they're signing in. They no longer have to present their Medicaid card, and members will not be, there are some additional services if it's not a covered benefit. The provider would have to work that out with them to make members aware that there may be some additional charges for those services that are not a covered benefit. And then finally, IntelliRide is also available to go to dental appointments. So members have the ability to be able to get a ride if they don't have reliable transportation. So what's your role in how to be able to promote good oral health? Scheduling a staff training if you're interested in being able to provide some additional information to your staff or any of the providers. I would be more than happy to come in and do an individualized training for your staff. If you have the option, if there's the availability to be able to post oral health and benefit information in your practice or on your social media or newsletters, please let me know. We work closely with a lot of the RAIs and also some medical practices around the state to make sure that they have all of our program materials and promotional materials. Being able to share that oral health information with the members, with the patients that you work with, you carry a tremendous amount of credibility when you're working with patients to be able to stress the importance of oral health. So we welcome the opportunity to be able to collaborate and share information with you so that you can share it with your patients. If there's an opportunity, if you have a member engagement, a member advisory committee, for example, if you'd like us to be able to come in and present, more than happy to do that as well. And then if you would like to take part in our Take Two to Make Two campaign with your front office staff, we have some program materials to be able to provide to members upon checkout to be able to remind them to be able to make both of those appointments. And that is it for me. So here is our contact information. If you have colleagues or interest in finding out more information or providing support on the Western Slope, my colleague Sabrina Crawford is, there's her contact information, and then you're always free to contact either of us and we can get you to the right person to be able to answer your questions.
Thank you, Sereny. A couple of questions sent to me for you. How were dental services impacted by COVID? And then a follow-up to that, what does telehealth screenings for oral health look like?
Yes, so not surprisingly, oral health was impacted by the COVID, and we definitely are starting to see it return to its pre-COVID rates in terms of accessing care. But as I mentioned, it's still only at about a 38% access rate, utilization rate here in Colorado. So we're hopeful that we are going to be able to get folks to be able to be not only aware, but also being able to access. We're going to be sponsoring some screening events around the state to raise awareness and hopefully get people in to be able to access their dental benefits. As of right now, the healthcare policy and financing has been quite clear around teledentistry benefits. It is still specifically for emergency screenings. Not sure if, I know that Dentaquest nationally, it has a really strong focus on utilization and expansion of teledentistry that hasn't quite reached Colorado yet, but we're hopeful that we might be able to see some expansion around teledentistry. But as of this time, it is only specifically utilized for the emergency services, emergency screenings.
Thank you so much. We'll put you in contact with any questions that come in. This presentation is being recorded and will be posted on our YouTube page.
Hi, everyone. Yes, thanks to Dentaquest for that great overview. And thank you for all that you do. Next, it's my pleasure to introduce two special guests. Today we have Jason Owens and Dr. Andy Meacham with us. Jason is the Administrative Director for the Division of Urology. And then Dr. Meacham is the Chief Division of Urology at CU, University of Colorado. And they're here this morning to talk to us about access to urology and what that looks like for a lot of the individuals that we serve here within our group, the Medicaid population. So I will turn it over to Jason to present.
Good morning. Thanks for inviting us, Heather. And as you said, we're going to spend a little bit of time talking about our division at CU Medicine and talking about what we've done recently and what we'll be doing in the future to address access in urologic care for CU Medicine Urology. All right. So first, I wanted to give an overview of our division and what that looks like. So CU Medicine Urology is one of the larger urologic practices in the state of Colorado. We have 42 faculty members, so that's inclusive of VAs, 15 residents, and 3 fellows. Primarily, those providers take care of patients at UC Health on the AMC campus, Children's Hospital Colorado on the AMC campus, VA and the VA hospital, as well as Denver Health. We also have sites at Highland Ranch Hospital and Cherry Creek Medical Center. And then Children's Hospital providers take care of patients across the network of care. So that ranges all the way down to Colorado Springs up into Fort Collins. Over the last year, through all of our providers, we saw more than 70,000 patients and did more than 25,000 OR cases. Something special about sort of our division, unlike other urologic practices, is that we're an academic practice, which means that our providers are busy taking care of patients, but also find time to do research and add to the global knowledge of urology. So that comes out to 33 active grants, more than 100 peer-reviewed publications, and 8 active clinical trials. And that was all done in 2020. So before sort of diving into the details about our practice, I wanted to provide some context of what urologic care looks like nationally, as well as within the state. So currently there's, as you can see, as the numbers indicate, there's a severe shortage of urologists in the United States. Right now, there's a need for more than 16,000, and currently there are only 8,500 practicing urologists. And that really comes down to funding of residency spots throughout the nation. A good example of that is the demand for our residency. We have 3 spots available every year, and we receive more than 300 applications for anxious and very qualified resident or medical students that are looking to get into the residency. Within the state, there's also a shortage of urologists. As you can see, many of the counties have 0 urologists per 100,000. And then obviously the most condensed population of urologists are in the metro areas, but much of rural Colorado outside of the I-25 corridor does not have easy access to urologic care. And similarly, just to kind of provide additional context is that one urologist can provide care for about 30,000 patient lives. And so there's a need for it to provide more access. There are some supply and demand issues that we're running into, but Dr. Meacham has been leading this division for more than 20 years, and we continue to come up with creative ways to provide additional access to the state of Colorado and even outside of Colorado. So new access that we've provided recently. So within the last 3 years, we've added three new community-based clinics. So that's off the AMC campus. So that comes out to 3 new attendings and 2 APPs. And we're always working with our hospital providers, Children's Hospital and UCH providers into the mix. One of the challenges, as folks know, is that, space is a huge problem. It's just finding a place and the staff and all of the things that come with providing bringing on a new urologist. So that's one of the limiting factors. But Children's Hospital and UC Health have been great in helping us grow our footprint across Denver and the Denver metro area. Additionally, we have programs and just processes and procedures within our practice to provide additional care. Our Highlands Ranch practice provides partners with Doctors Care. So we provide specialty care to Medicaid patients through that program. And those patients oftentimes may struggle otherwise to get urologic care elsewhere. We also have our APPs, Triage, new Medicaid patients, to make sure that if they're severely sick, if they have cancer diagnoses or major reconstructive needs, that we create access to those patients as soon as possible. Certainly we want to take that extra step to make sure that folks are getting the care that they need. As folks know, one of the silver linings out of this pandemic is a focus on telehealth, and our division has responded by growing our telehealth footprint outside of the state of Colorado. So we are working with both our pediatric and adult practices to provide access through telehealth in New Mexico, Montana, Wyoming, as well as Nebraska. In addition, we also are looking to provide access by going off the campus and out into the community through outreach clinics. So most specifically, one of our APPs at our pediatric group goes to the Fort Collins Youth Clinic a number of times a month and sees patients up there and has been doing so for several years. And then one of our oncologists we're hoping to create an opportunity for him to see patients in rural Colorado and do surgeries actually in a hospital outside of the AMC campus. So here's some of the numbers that I wanted to share with folks just to kind of see, what kind of access we've really provided. So as you can see, we've steadily increased our patients, or the number of patients that we see. And then also, as I mentioned before, we've substantially grown our telehealth program and seen more than 1,200 visits, on track for that for this year. So that's sort of what we've done. And so I want to talk about the partnership that we have with CU Medicine through the UPL program and HICPUF to continue to grow access to. So right now we're in the process of developing a transition, which will be one of the first, is the first in the state of Colorado. So the first question is, what is transitional care? So this is the transition from pediatric care into an adult care setting. And what that often looks like in a urologic setting is pediatric patients oftentimes will have a cancer diagnosis that will require substantial reconstruction of the urologic system. And so as they age, additional procedures may need to take place, but eventually that patient will age out of the pediatric care setting and need to transition to an adult setting. Oftentimes, if that transition is not smooth, the patient can be lost and will struggle trying to find that care. So what we've had the opportunity, as I said, in partnership with CU Medicine and the UPL program, is to hire a world-renowned transitional care urologist, Dr. Dan Wood. He's set to join us September 1. And so he will be based 60% at Children's Hospital, 40% at UCL Health Hospital, and will grow this program from we see some of these patients now, but it will be a true program specifically for this patient population. I think one of the real needs here too is that many of these patients are severely ill and are on Medicaid. And so I think that he's going to be able to see, or we plan to have him see, a large group of Medicaid patients. And we also plan to bring in an additional APP and hire a patient navigator to assist in that transition from Children's Hospital to UC Health. Dr. Wood is really known for building these transitional care programs, and we hope that through this experience in urology, he'll be able to coach other subspecialty care programs within CU Medicine to also create a transitional care plan and process for ortho, ENT, other subspecialty groups within CU Medicine. So another program that we started recently to provide additional access is our EConsult program. So what are EConsults? EConsults is a partnership between our specialty care providers and family practice and PCPs in the community. So how this works is that a PCP will register for this program. They will see a patient, and if that patient needs urologic care, they will send a e-consult or e-referral to one of our providers. That referral will have an H&P done, all the diagnostic work, any scans done, and then our providers will be able to look at that e-referral from their computer and assess and coach the PCP on if they can take care of that patient in their own office, or decide, does that person actually need to come in and see a urologist? So this helps access in two ways. Is that one, oftentimes folks, particularly if they have Medicaid, or they will be able to get into their PCP very quickly, and they already have an established patient or a relationship with their PCP, and so can have that ailment addressed quickly. And the other thing is that for folks that do not need specialty urologic care, they're not filling up slots, and the severely sick and the people that really need to see a urologist can have priority for those slots. So in about 2 years or so, we've done more than 250 of these e-consults. The ranges of diagnoses are from kidney stones, blood in the urine, elevated PSA. So we're really able to help coach folks through the entire range of urologic ailments and making sure that they can get quick access to care. And then finally, the other program that I want to talk about, and this is one that Heather and I have been able to work on and really start to grow, is ECHO Colorado. So ECHO, let me give you a little background on what ECHO looks like. ECHO started actually in New Mexico, where there is a provider who wanted to teach primary care providers how to treat patients that had hepatitis C. And so he had educational lunch and learns where he taught providers that were seeing these patients how to take care of these patients in their own clinics. So this idea has since grown substantially. There's a number of groups in CU Medicine that are part of the ECHO series, and we are just starting out on ours. And so we just finished our first boot camp on urology. We had more than 50 attendees at each of our boot camp sessions. And so that boot camp included how to treat UTIs, men's health issues, including testosterone hormone replacement and ED, elevated PSAs, and kidney stones. So it was a really successful boot camp, and we were able to get folks as far as Durango at these, and then people even within the CU Medicine system attend these sessions. Going forward, we plan to have a longitudinal curriculum for ECHO Colorado for urologic care, where we'll be able to really dive deeply into a number of topics, including pediatric urology, issues that are specific to oncology, as well as women's health issues within urology. So that's a little bit of a summary of our program and what we're doing to increase access. I think the summary here and the takeaways are that there are some challenges, but I think that through partnership with some of our hospital partners, CU Medicine, HICPUF, and the UPL program, we are trying to come up with creative ways to continually provide access to as many patients as we possibly can. Wanted to pass it to Dr. Meacham to see if you had any comments that you'd like to share.
I do, Jason. Thank you very much. That was a really nice presentation and a very concise and helpful representation of what we're doing. Let me sort of maybe back off to the 20 or 30,000 foot level and say, at least from the perspective of a urologist, there was a tremendous amount of drama and a lot of, appropriately, a lot of concern, a lot of attention focused on the COVID-19 pandemic. Certainly it's been a tremendous challenge for all of us in healthcare, but I would say one of the many sort of unfortunate aspects of the COVID-19 pandemic was that it diverted attention, at least temporarily, from what I think is really just a tremendous public health issue. And I think everybody on this call would probably agree, and that's access to care for people that are financially disadvantaged and are geographically located or geographically located where it's hard to access specialty care. In urology, that is particularly acute. As you mentioned, as Jason mentioned earlier in the presentation, we have chronically had a shortage of urologists in this country for decades. And as he also pointed out, at minimum, they now feel like we need 16,000 to 17,000 practicing urologists in the US, and we have somewhere between 8,500 and 9,000 urologists. So just starting off, we have about half the urologic providers that we need. The reason for that, and it's interesting, it's kind of been controversial going back and forth as to what caused that. Many people said the ACGME, the Accreditation Council for Graduate Medical Education, was not authorizing enough spots in urology, or their residency review committee was not. I had the opportunity to chair that community for several years. And I can tell you, it's not the ACGME, it's that it's very expensive to fund and train residents. And there are not enough salary lines right now available to expand residency programs. So we're probably not going to be out of that box for a while. One of the downsides to having such a shortage of urologists, I'm not sure people really see or get until they start looking at the situation on the ground, is that because there are so few urologists, every urologic provider is just swamped with patients waiting to see them. And what that has actually allowed is for urologists to be very, very particular about who they see. So they are oftentimes going to focus on advantaged payer mix, patients with an advantaged payer status. I think that outside of Denver Health, we at the University of Colorado are among the only urologists that I can find that routinely do see non-emergent patients that have Medicaid as their primary coverage. So that tends to funnel an already large population of patients that need care into a very limited set of resources. urologists around the community will see patients that have Medicaid if it's an emergency circumstance, if they're on call and somebody has an obstructing stone or a Fournier's gangrene or something that just has to be managed, but it's pretty uncommon. We're told by the patients that we schedule that anybody else has said, yeah, we'll be happy to schedule you into our practice. I sort of did some rough calculations recently and said if we were going to actually provide prompt and efficient care for patients that have Medicaid that fall into our catchment area, how many urologists would it take in going to with 30 to 40,000 patients, patient lives per urologist? The answer is for our University of Colorado Hospital program, we have an eight adult urologists. I would need to hire between 10 and 12 additional urologists that only saw patients with that have Medicaid as their primary provider or a payer to be able to bring that into a reasonable alignment. Recently, we have been seeing a lot of significant number of patients from Denver Health that have Medicaid have been referred to us because of their own challenges with workforce. They have only 3 urologists, their third just came online. Also, we are struggling again with just sort of managing patients that have Medicaid as their primary payer outside of the Denver region, which is what usually is assigned. That population of patients are oftentimes or traditionally cared for by Denver Health. So from the very beginning, we have such a mismatch between workforce and patients that are in need of care that, as Mr. Owens mentioned, we have tried to think of ways that we can address that issue, short of just hiring more urologists, which we're doing. We've put on 4 additional faculty, MD faculty, and a number of additional advanced practice providers in the last 3 years, in no small measure to try to manage this situation. The other thing we're doing is as Jason pointed out, is we are trying to provide training for non-urologic providers to be able to manage part of this huge population of patients that have urologic needs, and through both by doing EConsults, so we can directly do that patient by patient, and also the ECHO program, where we just give as much information as we can and then remain available for virtual consults for providers across the state who are managing patients that have potentially lower acuity urologic care. One of the problems is if you have a patient that lives remotely, who lives a long distance from Denver, if they have financial challenges, it's oftentimes more difficult for them to travel. If they're going to need to fly or they need to drive a long distance and they potentially have childcare issues and have a hard time managing that, it's hard for them to travel to Denver or to Aurora. So that's one of the reasons that we're outreaching, providing outreach, not just for the metro area, but also in more rural locations. And then lastly, the transition program we're very excited about, because many of these patients who are transitioning from pediatric care to adult care have got very, very, very complex medical conditions. Many of them, a tremendous number of them, have severe congenital anomalies, spinal cord anomalies, other things which make it very, very difficult for them to have usual or normal mobility, to be able to find consistent employment. It's oftentimes a tremendous challenge for them. Transportation is a challenge. So they leave the pediatric realm because they've now become adult in age, and they move into a place where they've got 2 challenges. One, many urologists simply are not experienced enough in the complex reconstructive procedures they have had to be able to address the issues that will always come up over time. And number 2, they're in a particularly vulnerable spot in terms of finances because they oftentimes have never been able to achieve employment and may never be employed. So that is a critically vulnerable population, and we are so pleased to be probably the only group in this part of the United States, definitely the only group in this part of the United States that will have a specialty provision of care for that extraordinarily vulnerable group of patients. So we're pleased about that. I guess I would just like to conclude by saying that we are incredibly aware, acutely aware of our inability to provide the level of care, the amount of care for patients that have Medicaid is the primary coverage. In this region, we are working as hard as we can to try to bridge that gap. We encourage community urologists also to see as many patients that have disadvantaged payer status compared to those that have private and commercial insurance. We make some progress with that, but again, every urologist is swamped with patients, and they oftentimes are relatively selective about who they will see. So I want to thank this group for getting together and strategizing ways that access can be improved. We are certainly committed to it. We would be happy to spend as much time in the future as would be helpful in sort of strategizing with you. But it's the one part of our practice that I just sort of feel like as often as we get up and we come to the office and we do our very best, that it's hard to gain traction and really do the things we need to do. But we are trying our best, and we do appreciate the support in bringing Dr. Dan Wood, the transitional urologist, to us, and also helping facilitate the ECHO program that will let us reach out. So that's it for my comments. Again, thank you so much for letting us have this time to visit with you.
Thank you so much to our presenters, Jason Owens and Dr. Meacham. We know that you're coming up with a lot of creative solutions to try to meet the demand, and there's a lot of demand out there. So as much as the Aurora Health Alliance can help you in that charge, here to problem solve and find solutions together. I did get some questions sent to me. Mandy got some as well. Rich, I think you just sent one in the chat, which is the urology department has a relationship with Doctors Care. Do you have anything similar with Stride or Salud? And there was a similar question just around access specifically in Aurora.
So Jason, you may be able to tell me if I'm wrong about this. I don't know if we have a formal articulated relationship with either Stride or Salud. We do see a lot of patients in combination, and Tina Finlayson may have an answer from the CMS perspective. I was just involved in a lengthy email exchange regarding a number of our providers at Stride and some access issues. And we were trying to strategize ways that we could improve that specifically for one patient that would apply to all patients. So we see a lot of patients in partnership with both Stride and Salud. Tina or Jason, formal relationships that have been codified beyond that, I'm not aware of.
Yeah, this is Tina. And so with Stride and Salud, they are both on our EConsult platform. And plus we have, we already have developed pathways for referrals that have been in place for decades. The referral pathway at Doctors Care was a result of our extending into Highlands Ranch so that we were more co-located in that community. And that's, they're not able quite yet to go up on EConsults, but we do have a formalized referral pathway for them also. So yeah, we extend to all of those organizations.
And in regard to Aurora, I mean, specifically, we see, as you would expect, a tremendous number of patients from Aurora. I don't know if there's a more specific aspect of that question that I should address here.
Yeah, the question was just around access in Aurora. Is there anything to improve specifically Medicaid access? And I think you answered that. And Susan Todd is a director at Stride, and she's joining us today and typed in yes, that they do have a relationship. It looks like, and I know that the EConsults are flowing. Susan, did you want to add anything to the Stride partnership?
Yeah, I don't think we have like more of a formal like written agreement, but I know that we do and have that relationship, and I mean, it's a struggle, right? It's a struggle when you don't have enough urologists and enough access, and just that's a reality, and it hits regardless of payer, but it is, to your point, much more pronounced with patients with Medicaid or are uninsured or patients who don't have a lawful presence. And so it's just trying to make sure that we keep those pathways open and that we utilize the tools that we can between EConsults or, happy to hear, trying to find other providers outside of the state to fill some of this need. And I think it's always important to kind of focus and try and make sure that people are able to get the care that they need regardless of their insurance card. And so how do we try and support a system that is really supporting everyone? But that is the challenge.
And one of the things that Jason touched on is how we triage patients when there's limited availability for providers, and it's a hard balance to strike. One thing we would try to do is not make it too long until someone can be seen by a urologist. The other is we try to look at the acuity of the condition they have and try to say, gosh, is this something that potentially could compromise someone's, survival? Versus someone that has been waiting a long time for something that's not life-threatening, but nonetheless is having a severe impact on their quality of life. And it's an ongoing struggle. So we try to do both. We try to keep the waiting time as low as possible, but also try to get patients in where, weeks or months could really spell a significant difference in the outcome of their care, cancer being a good example of that.
We had about 3 or 4 more questions. I know we have one more agenda item to review, get an update on the survey that's being done in the Aurora community. But there was a specific question around the cost utilization and seeing an increase in emergency room use around chronic UTIs, specifically in the Medicaid population. And so anything going to address that increase in emergency room use and things that you're seeing particularly around that within your own clinics?
Yeah, I mean, it's a great question. And it's another manifestation of the problem we have when people, and it's one of those ironies that if you can't see patients in just a regular clinic setting in a timely fashion, and anybody that on this call that's ever had a UTI or known anybody that's had a UTI, that is an acute situation. I mean, they're miserable, people are ill, it's a terrible circumstance. When we have to, when their care gets shifted from our clinic to an acute care facility, number one, it really packs that acute care facility with additional patients, making it very hard for them to manage the patients they're seeing currently. And number two, it escalates the care tremendously. A simple visit with a urine culture and a urine analysis with an antimicrobial prescribed is relatively straightforward, but someone who has to go and wait several hours sometimes in an emergency facility and then has the escalation in cost, it's incredibly unfortunate, but that's what's happening. People have got an acute need. They need to be managed quickly. They seek whatever resource they can, which is oftentimes the most expensive and the least accessible. We're hoping that that's a really important topic in our ECHO program to help familiarize people with the fact that the vast majority of urinary tract infections, don't need to be seen by a urologist. Recurrent infections in the presence of a urinary stone, we need to see those patients. And by helping providers differentiate, we're hoping that they'll be able to carry part of that load and then send those patients that really do need to see us to our facility. But that it's what's happening. I mean, people are unfortunately inappropriately having to seek care in more acute settings because the usual setting, which is our clinic, is just we have minimal availability. So we're trying to expand that footprint both by bringing more urologists and training others in that management.
Great, thank you so much. We'll go ahead, if it's okay, Dr. Meacham and Jason, send the other questions along to you via email and ensure that this group gets access to the response. But knowing that we're coming up on time, Dionisia, I wanted to pass it over to you because you and your team have been doing some exciting work in Aurora around serving the need for additional data around where there might be gaps or barriers in access to specialty care. So we'd love an update on how things are going.
And let me just say briefly, I'm sorry to say, I'm going to log off because I'm in my clinic seeing a bunch of urology patients. If anyone would like, if I can assist in any way, either community outreach, strategizing, that sort of stuff, please email me directly at the medical school. And thank you so much for your time.
Yeah, thank you.
Yeah.
Thank you. Oh, there you are.
Okay. So someone is sharing my screen. Thank you so much. So I know we just have a short amount of time. So most of you are familiar with this project. It's been ongoing for a little over a year. Dr. Kerry Mader and I have been working on it, and I've listed out the other volunteers, which is a mix of medical students, some folks from the Practice Innovation Program. I'm fortunate enough to work for the Practice Innovation Program, which if you're familiar, some of you may be familiar, they have some UPL funding for the Innovation Support Project. And my boss, Perry, is very much behind this, me doing this work. Next slide, please. I want to talk a little bit about myself. I show up first as a community member, and then I work at the University of Colorado. And this picture just tells a lot about my lived experience in specialty care access. So when I showed up to that meeting where I took on this project, I didn't even know what specialty care access was, the term, but as a young mom, I was 19 in that picture, working at McDonald's, high school dropout. I very much have experienced firsthand this Medicaid challenge. And in fact, my teen son, who had to get up the courage to tell his mom that he needed a urologist, going to the primary care provider, and then the anxiety of like figuring out how I was gonna take time off and be able to afford and deal with whatever came of going to that specialist. And long story short, it ended up being like they just told him to pee more often. There wasn't any major procedure, so it probably could have been handled in primary care. And then my work experience, I've been with the University of Colorado for almost 20 years in a variety of spaces, but research and evaluation and data is my jam. And that's where I'm showing up. And the reason why I bring this up is because we really do need the experts in specialty care and all the nooks and crannies that it impacts to help us solve this puzzle for Aurora. Next slide, please. And so I'm going to tell you a little bit about the survey. It's got about 85 to 100 questions. And the way we did it was we created a very brief survey at the beginning that really just asked what the top 5 needs were and what the bottom 3 needs were, both for Medicaid and uninsured. So what are your top 5 problem specialties that you really struggle with getting help with, and what are your bottom 3 that you don't even think about and you're able to get the referrals to? And then we actually, using a safety net study, we found a cool survey that kind of dug into that a little more with around 50 questions that both are closed and then and kind of lay out some common barriers and solutions, but then also a lot of open-ended stuff about the barriers and solutions of these folks that are filling out this survey. And so far we have 55 respondents, and I'm going off of memory here, so forgive me, I'm on the slides. So 55 respondents, about 16 clinics, about 6 or 7 of those are Stride clinics, but different location. And then more than 50% of respondents said that specialty care access for Medicaid and uninsured was either somewhat difficult or not possible for their experience. And then we had a really great response rate. And this is, to me, this speaks to, one, the need, but also the passion and desire to solve this problem for Aurora. 68% of our respondents said that they were willing to do that longer version of the survey, which is, again, another 50 questions and a deep dive. And so that's where we are. I've summarized, and just so I'm going to put my data hat on real quick. I've summarized the data, but it's too early for me to share specifics because I don't want to mislead on what we're finding. But we also need to dig into those to the open-ended questions. And I'm going to come through with my lived experience lens, and Kerry Mader comes in with her doctor hat, and like the urologist that was on, he's going to have a different lens for those open-ended questions. So the more we can get different folks to help us kind of get into this data and then help us tackle how to start to chip away at solutions, the better off we'll be. Next slide, please. And so here's how you can help. We're always open to having more surveys completed, and we mostly want to stay in Aurora, but because I'm with the Practice Innovation Program, it's not a bad thing for us to get outside of Aurora because it might tell us solutions that we didn't think about in Aurora, if that makes sense. But we really are trying to get Aurora providers, referral managers, folks in Aurora that know the problems and solutions that can be done in Aurora. And so the link to the survey is there, and I'm going to put these in the chat in just a second. I also need helpers. And so I have a survey where you can tell us how you want to help. And then if you go to the next slide real quick, I'll show you the levels of ways you can help. So you can be an expert or a connector. And that's somebody that maybe you just know a lot about EConsults, and we can just, we come up with a solution or an idea of a solution, and we can just meet with you and kind of dig into the details, and you can help us get connected to the workers. Or an action-oriented partner is someone that maybe works at a specific clinic or a specific health system or a specific area that can kind of dig into the details for their area. And then just straight up workers, we definitely are in a good place now. So we really are at that point of where we have good data, and we could start really kind of thinking about, the working group could really start thinking about next steps and solutions based off of what we're seeing. And so I will put the link to that survey in the chat. And then next slide. I know this is super blazing fast, but now it's time for questions, because I know I went through a lot of that quick and want to make sure I answer anything I left out. And I'm putting all of my links in the chat. So those are the survey to sign up, and then my email and my Calendly if you want to schedule time with me. Any questions?
Wanted to take a moment and say thank you, Dionisia. And I know Regina, Dr. Regina Richards is on, and her time is packed, and she's specifically listed as a in the thank you here. So I just wanted to take a moment and say thank you, Dr. Richards.
Yeah, this is such important work. And I think what I appreciate is that you're doing it in a very methodical way. And although we all want the information sooner than later, I think it takes time really to get everyone's level of engagement and the in-depth analysis that you're doing. It's not just surface level, it's really asking some of those critical in-depth questions. And I think that it'll play a role in any future activity that we all decide to partner around once we can have some more of that data to really dive into. So knowing that there's some partners that have not completed the survey, are you comfortable with us directly forwarding that survey?
Absolutely.
And would you like just like a warm handoff, or what's the appropriate connection for you?
You can just give them the link and have them fill it out. That's perfectly acceptable. I was lucky enough to get Allison Gottsman on the team, and so she's been helping a little bit with recruiting, because that's what she does for the practice innovation program. But that's really what I need. I had a student helping with that, but anybody that has those relationships, and and this is the other part of this work, is really the heart of this work is how we're going to kind of continue to move this forward. And so people like Molly is the one I always give an example of, like, your heart and what you said at that first meeting is what's driving me doing this work and coming up with a solution or thinking about how to move this forward. And so you and your connections with the community are going to be maybe we'll get a provider or a referral manager to fill this out where they don't know who I am, right? And so and that's the other piece, right? If we could wave a magic wand, we would be looking at provider's perspective, specialist perspective, and patient's perspective. And we may get to that at some point, but we felt like this was a good way to start to chip away at this with no funding. I'm fortunate enough to have two amazing bosses, Dr. Richards and Dr. Perry Dickinson, who are supportive of the community work that I do. So they allow me to use resources and the space to do the work, but I continually remind them that this is a community-led project, and I'm showing up first as a community member. So I hope that answered.
Yeah, and it's just, I think there's a lot of people, on this call where this is our passion. We want to create better access. And so, yeah, just a reminder to anybody, if you do have those connections, I think it does help to have those warm handoffs. If you know practice managers or individuals working in different settings, that you can forward the link along to. And it is an in-depth survey. So I think also preparing people for that, to really set aside some time to think about it and dedicate the time to completing it. So we appreciate the update today and are very excitedly awaiting for the results.
Yeah, and so we hope to have more by October when we meet with you. again. And I, if anyone knows me, I work with a lot of students, and this is one of the projects that I list on my community initiatives that they can be involved in. And so far, just since I posted this in the last month and a half, I've already had 3 students that specifically want to work on specialty care access. So I have one that's voluntary now, and I have 2 more meetings coming up. And so that's where we can start to think about, you know, doing other innovative things with the data, or, you know, doing more in-depth interviews or something. I don't know yet, but just so you know, we're always working on it. And then I'll just say one more thing. If you sign up on that form, please know that we don't waste time. And Regina knows this well. We have meetings to get things done, not to just meet. And so the actual specialty care access group meets once a month at 8 on a, but that's even optional because a lot of the work happens in between. So don't be afraid to sign up if you have knowledge and information that can help us move this work forward. Okay, thank you.
Dionisia, this is Rich. Thank you for your energy and passion and drive on this. It's remarkable that what you're doing and your outreach to community. Dionisia, I'm trying to get the sign up link to work, and it doesn't seem to be working. I just copied and pasted it, and I'm getting some type of error.
The bit.ly isn't working. I'll send them out again. I had to hand type them because my internet went down, and so they're in the slide, and I'll send you guys the links.
We'll ensure they work with our meeting follow-up email to this group as well.
Thank you.
Yes.
Are there how does it work if I want a slide, the previous slide? If I want a copy of that, what button do I push? I know it's being recorded.
Molly, how about I download the PDF for you and send it to you?
You did what?
I can download the PDF and send it to you.
That'd be awesome. Thank you. I will put it to hard work. Thank you.
So before we adjourn, any other questions, comments, concerns, shout outs?
Yes, thank you all so much for this information today. It was really helpful and useful, and it makes me think about, okay, how do we gear up and do some things, maybe even a little differently than what we're currently doing. I always want to give a shout out to Dionisia for the work and her dedication to community. And I also want to thank you all who are on this call that are so dedicated to the Aurora community and the outreach work, not just outreach work, but the inward work that you are doing to improve the health and the health outcomes of the community. I also want to give a shout out to my team members who are here, Tessa and Neil, who are very passionate about community engagement as well. Dionisia has led us in so many efforts and always showing up with their expertise, but making sure that this is community centric. So always appreciate the work that everyone is doing. We wanted to always give her a shout out because she never wants it. So, so thank you all so much.
Great, thanks for that shout out, Regina. Appreciate that. And just thinking of the Office of Diversity, Equity, Inclusion, and Community Engagement, it might behoove us to think about with your Health Alliance, how we can maybe have you as a quarterly Did You Know panelist, just so we can get the word out more about the work happening to the broader community. So just a note outside of access to specialty care.
Yeah, I would welcome the opportunity, definitely. And the most important thing is to get those dates so that I can make sure that they get on the calendar. But more than that, it is, okay, so I see the next one. You know, how can we really be intentional about, you know, as Dionisia and Tessa and Neil are involved in this work, you know, how can we really continue to update you all, but to hear from you all to say, how can we leverage our platform to be much more inclusive with the work that is being done across the spectrum.
Absolutely. Well, what a great meeting. Lots of good information. Thank you for everyone that was able to attend. And the next Access to Specialty Care meeting will be in October, I believe, right, Mandy? And then we also have our,
sorry, the time and date are all in the chat.
oh, thank you.
Yeah.
And then our quarterly meeting will be next month. So if you're able to join that, look in your emails for updates on our next quarterly meeting. Great. Thanks to everyone. We'll go ahead and adjourn.
Thank you.
Bye, everyone.
Bye.